Good evening, everyone. Welcome to today's CME. My name is Dr. Kalu Agnes, and today our moderator will be Dr. Lily Nyamai, a glaucoma specialist and a lecturer from Kenyatta University. She'll introduce our speaker for today to continue. And let's give them just a minute. The speaker is having some problem logging in, but we should be starting presently. Thank you.
Hi, Nir, how are you?
Hi, sorry for the delay. How are you?
We're fine, thank you.
And thanks.
So, Dr. Lily, I think you can go ahead.
So, Nir, I've been asked to introduce you. So, as you upload your presentation, good evening, everyone, from wherever you're listening in. And please feel free to type in the chat box where you're listening in from. So today we are proud to have with us Dr. Nia Shoham Hazon as our guest speaker. Dr. Shoham Hazon is a versatile eye surgeon and physician. He's a glaucoma, cataract, and advanced anterior segment surgeon based in Miramichi, New Brunswick, Canada. Dr. Shoham Hazon completed his ophthalmology residence at the Kaplan Medical Center in Israel in 2010. And Dr. Nia Shoham is one of the most exceptional ophthalmologists I know, with an incredible track record. He was the chief resident and received top awards as outstanding resident for the Kaplan Medical School Center, as well as the Outstanding Resident Award for the entire School of Medicine at the prestigious Hebrew University and Hadassah in Jerusalem, Israel. Dr. Shoham Hazon has pursued the highly competitive fellowship at the University of Toronto with the world-renowned Dr. Ike Ahmed, one of the pioneers in the new advancements in glaucoma surgery. This is a 3-year fellowship, and it included clinical, surgical, and research aspects of glaucoma, advanced anterior segment, and IOL surgery. It's also known as the GAS Fellowship in the University of Toronto. So Dr. Shoham Hazon has received several awards for presentations in international conferences and research grants for numerous research studies, including the phase 3 dermatoprost implant clinical trial. During Dr. Shoham Hazon's career, he's transitioned from academic practice to independent practice and is currently an independent private practitioner as a glaucoma and an advanced anterior segment surgeon in Atlantic Canada, where he's the director of the Miramichi Eye New Brunswick Center of Excellence. Dr. Shoham Hazon is a clinical assistant professor at the Dalhousie University and the Memorial University. It's an honor to have you, Dr. Nia Shoham Hazon. So Nia, take it away.
Wonderful, thank you, Lillian. Thanks everyone for attending. What I'll do today is let me share my screen. So let's see. So what we'll do today, and do feel free to ask any questions, and Lily, feel free to kind of stop me at any given point. Let's see. Okay, can everyone see this? Is it okay? Have to, one sec. Okie doke. So basically what we'll talk about today is minimally invasive glaucoma surgery and future frontiers. So Lily, feel free to kind of do stop or something. I can see you on the side of the screen. So if everyone or anyone has a question, I'd be happy to answer. What I want us to try and focus today is what I practice on a daily basis and what I focus my surgical practice on, which is minimally invasive glaucoma surgery. And what we'll talk about today is future frontiers. So I must admit there's not going to be a lot of evidence-based data and numbers. I want to go over the different minimally invasive glaucoma surgical techniques that are available. I'll tell you what I practice. I'll tell you what are kind of future frontiers. And these are my financial disclosures. Some are related to minimally invasive glaucoma surgery. And actually, I'm involved in a office-based MIGS procedure that we might actually bring to Kenya one day, maybe sooner rather than later. So we'll be happy to collaborate with you guys. So the outline for the talk, I'll do a very short history around minimally invasive glaucoma surgery, talk about current treatment paradigms, and talk about the new frontiers in surgical glaucoma. So everyone is, I'm sure, familiar, whoever deals with glaucoma surgery is familiar with this face. So Ike Ahmed is a world-renowned glaucoma and advanced anterior segment surgeon. I had the fortune of spending 3 years with him. And probably around when I started 2010, when I started my fellowship, we did come up with all the minimally invasive glaucoma surgery technologies, and Ike was a pioneer in developing them and innovating and improving whichever technologies were on the market. So minimally invasive or micro-invasive glaucoma surgery is probably beginning to be kind of almost a decade long. Having said that, only few of the technologies are FDA approved for that long. So when we talk about minimally invasive glaucoma surgery, there are basically 5 major tenets for MIGS. And one, it has to be done through a clear corneal incision, either involved in with cataracts, with phaco or not. It should allow minimal trauma to tissue. So you always have to have an option for future surgery. Conjunctival sparing, because the idea behind MIGS is that it will allow us to do a trabeculectomy in the future. Minimal risk. So as the name is minimally invasive glaucoma surgery, it should allow minimal risk to the patient's eye and tissue. And something that's not, it's 5th on the tenets, but is probably as important, is the minimal effect on quality of life. So I'm sure we're all doing trabeculectomies and tube shunts, and we kind of tell patients that recovery is probably one of the major hurdles in glaucoma surgery, which is, you know, sometimes 4 to 6 weeks. Sometimes they recover faster, sometimes they recover slower. So that's a major part with minimally invasive glaucoma surgery. And I usually tell my patients that typically, like a cataract, within a week, you'll be back to almost normal. It depends, of course, which MIGS we're talking about, whether it's an angle-based MIGS or subconj MIGS, but this is something that we also care about. So quality of life is what we're all about. So when we talk about the treatment paradigm that we have today, we still know that we start therapy with topical therapy, which is drops, or laser trabeculoplasty, either ALT, SLT, or the more newer technology, which is MLT, the micropulse laser trabeculoplasty. Lily, can I ask how many of you do ALTs or SLTs or maybe MLT? Does anyone do micropulse laser trabeculoplasty?
I'm speaking for myself. I don't think we do MMT, but I think a couple of us, and people could type in the chat box. We do either ALT or SLT.
Okay. Okay, so that of course we know is a major it is a good technology, and we'll see one of Ike's current kind of statements about compliance and adherence. We know very well that if we give patients a prescription, not always do they know how to really apply the drops themselves. So that's always kind of a hurdle with topical therapy, hence laser trabeculoplasty. And we have the big light study now that tells us that laser trabeculoplasty may be as good as, if not better than drops. And so that's always kind of how we start. I kind of find that my population here in rural Canada may be a little more conservative. So if I ask a patient what they'd like to have as their first line of therapy, drops versus laser, lasers always has the connotation of laser surgery, although I tell them no, it's a small procedure and it's painless. So people still kind of think some prefer to have drops more than laser. And the second step or second line that we have available to us now is, of course, either applying minimally maximal tolerated medical therapy for patients. So kind of throwing the kitchen sink of whatever they can tolerate in terms of drops, rarely also oral carbonic anhydrase. But we do have non-incisional MIGS, which we'll kind of talk about as well. I refer to non-incisional MIGS as micropulse CPC. So micropulse CPC, we'll kind of see it in later in the talk, is a milder form of cyclophotocoagulation, which I actually perform in my office. I'll show you a video of how we do that. And it's not as invasive as continuous wave cyclophotocoagulation. And of course, we have minimally invasive glaucoma surgery, which can be introduced into the treatment paradigm earlier than our tubes, our trabs, or other procedures. So that's kind of how I see my glaucoma practice. So what I'll be doing is discussing this paper, which was written by Ike and John Samples, who are huge glaucoma icons. And it was actually published in the Glaucoma Today. It talks about glaucoma pipeline, view into ongoing innovation. And it actually is an editorial that deals both with a view on the surgical pipeline and the pharmaceutical pipeline. And what I'll try and focus today is on the surgical pipeline. But this glaucoma pipeline editorial is available for everyone. So you can easily Google it and see it on Glaucoma Today. And I'll be focusing on the surgical pipeline today because I find that this will be way more applicable to our day-to-day practice and yours. So I started this editorial by saying that the procedural management is quickly becoming a popular option for patients with glaucoma. And the reason is we know it eliminates the adherence issue and also topical side effects. And for those of you who might have dry eyes and have to use drops on a daily basis, I'm sure that all of us kind of find it hard to adhere to a regimen of putting drops, especially in early stages of diseases where patients don't really understand why we make them take drops, which irritate their eyes, cause redness, sometimes maybe some cosmetic issues around the eyeball, and they don't feel anything. So if we can intervene with a safer procedure at an earlier stage, sometimes that can be of benefit to the patient's glaucoma progression. So in this editorial, it kind of goes through nicely the different points of where and how we can treat glaucoma surgically. And what I will do is go kind of through step by step of the different surgical interventions that can be helpful and that I see some promise in. Some I do have personal experience with, and I'll tell you what that is. And others, as you can see, are investigational. So for the first step, the drainage to the ocular surface. So there are two current technologies under investigation. The one that I want to show you is the Beacon Aqueous Microshunt by Microptics. And basically, we'll see that it's an implant that delivers aqueous or drains aqueous through the cornea, which is kind of a little bit of a remarkable thing. So what I'll do is I will show you YouTube videos of each and every of these technologies. And Lily, you'll just have to tell me that everyone is seeing this and that you can hear it, because sometimes I'll do voiceover, but sometimes I'll just kind of show you what is on. So it should open YouTube. You're seeing it's opening?
Dear colleagues, it's a pleasure to present this device for the first time.
Okay, hold on. Because we tried it. You're not seeing this?
Time worldwide.
Link, but I'm not able to see the video. Maybe you could share another tab with the actual video on it.
I can. Let's see. Because when we tried it yesterday, okay, now I get it. Okie doke. Can you see it now?
No financial interest. We are conducting trials.
Super. So what I'll do is I'll just increase the volume just to make sure that we all can hear. Let's see. I'll share sound.
Pay for our work, but that's. And if I look at what I would love to have and see is a glaucoma implant that is not dependent on.
Can you hear not so well? You can hear. So basically what we have, this device, we'll see it, it's a small gentle leaflet. I'll just kind of advance, and if there's any issues, you just let me know. So this is the implant. So it's basically a 3 millimeter implant that will allow aqueous flow from, so I'll go back a little bit. So it will allow aqueous flow from the anterior chamber into, so we can see it here. So allow aqueous flow from this end, which will be in the anterior, inner opening in the anterior chamber. And the outer opening will actually be in this, not subconch space, but actually in the tear film. So it allows aqueous percolation into the tear film. So anytime we see a Zydel, we're kind of always, maybe on a phaco incision, we're always very wary, but this will allow a unidirectional flow of fluid from the AC to the tear film. And this laminar flow basically doesn't allow retrograde, so there's no risk of endophthalmitis or infection. I'll just move ahead a little bit so we can see the surgical video and the histopathology. I'll turn the
histologically looks like. And this is the video, very briefly, very quick, easy surgery. Most of my patients are under anticoagulants, and this is surgery that's completely independent on anticoagulation. So bleeding or something like that, which immediately stops healing, etc., and other technologies, and I have no financial interest, would immediately mean the end of the surgery. And this is performed under topical anesthesia, and here you can see the fine outflow.
So we can see the fine, everyone saw kind of the fine kind of Zydel from the Vision Blue. So this is one type of new technology that is basically, we can see it's minimally invasive through a clear corneal incision. And if in the future one needs a more invasive procedure, it can always be carried out. Let's see if I move to, can you see now the continuation of the slides? Okay, fantastic. So that was kind of step one. So step one was dealing with the cornea and the microptics implant, which seemed pretty intuitive. I don't think we need to be great glaucoma surgeons in order to implant that. The second step is at the trabecular meshwork stage. So it's the aqueous outflow at trabecular meshwork. And we have these three technologies, the trabectome, the Cahook dual blade or KDB, and the GAT, gonioscopy assisted transluminal trabeculectomy. And I guess I'm fortunate enough to have used all three technologies. I'll tell you my favorite, and I'll tell you something that can actually be, those are technologies that can actually be very applicable in your neck of the woods for different reasons. And we'll just go ahead and see if we can see them. Again, we'll show videos. There will be a voice on them at any point. If we need to discuss or explain some things, I will. So Lily, tell me if we're seeing this. Awesome.
The trabectome is a microelectrocautery device designed to incise and remove the inner wall of Scham's canal. The sharp tip footplate is used to incise the inner wall here, and you can see the direction we're going in is in a counterclockwise fashion. Once we have placed the tip into the canal, we see the filament now being discharged here as we move the element over in a counterclockwise fashion. We typically use about 0.8 to 1 millijoule and move in a very careful fashion here, following the contour of the angle here, rotating our hand along the incision and ensuring that the footplate is parallel with the outer wall to avoid engaging the sclera and the outer wall. We see now the inner wall has been incised for about 45 degrees, and now we turn the tip here. The sharp tip is now placed again inside the canal here, and the discharge from the filament, microelectrocautery filament, is used to incise and cut the inner wall, typically doing about 90 degrees to about 120 degrees in the nasal angle. Once it's been performed, you can see the so-called cleft form here, the splitting of the inner wall here, showing actually a number of collector channels nicely filling with blood reflux. This is a nice example showing the distal outflow system, the outer wall collector channel positions here, filling with heme as the IOP is reduced in the eye. We typically perform the procedure with irrigation. Viscoelastic is used to protect the cornea, and the inner wall is incised with the element as seen earlier. Again, just with time, we see the blood reflux into the eye from those collector channels. Now we're going to inject some trypan blue through the area of the trabectome effect, showing the filling of those distal outflow aqueous and episcleral veins, nicely showing patency within the system. Further irrigation also causes blanching of those same aqueous veins, again showing that we've now bypassed the inner wall resistance directly into the collector system, distal outflow system. And when we compare the aqueous episcleral veins in the temporal quadrant compared to the nasal quadrant, we see the blanching in the area of effect.
After the...
Sorry. So, so this was one technology. Let's see. We don't want to see Ike with his hat. Sorry about that.
Lockdown.
One sec, I apologize. So has anyone had experience with a trabectome? Yeah. So I think my first ever MIGS was a trabectome, and I think it's a very nice device. They have kind of changed the way it works now. So this was a console with electrocautery connected to an irrigation, and the electrocautery and an irrigation and an aspiration port. Now it can actually, they call it TrabX, and it can actually be connected to the phaco machine. So you don't have to have the whole console on its own. Studies are the longest term with trabectome because it has been on the market probably for about 15 years now. The next device is the Cahook dual blade, which kind of is similar to the irrigation aspiration electrocautery of trabectome, but it does not have, so it's a static handheld device that is basically, it's a blade, so it doesn't require any external devices. Let's see how that goes.
Knocking out glaucoma with the new Cahook dual blade. My name is Dr. Constance Okeke. I'm a glaucoma specialist, cataract surgeon, and a MIGS coach. Today I'd like to talk to you about the New World medical device called the Cahook Dual Blade. It was recently launched in the fall of 2015, and it was engineered to excise trabecular meshwork tissue using precision micromachining and laser cutting technology. One of its key features is a ramp that puts the trabecular meshwork on stretch as the device is advanced, which aids in the clean excision of the trabecular meshwork with the parallel blades on either side. Let's go over the steps of the procedure. The Cahook Dual Blade can be used either alone or in conjunction with cataract surgery. Here I make an initial temporal incision, followed by anesthetic and then viscoelastic to fill the anterior chamber. The Cahook Dual Blade is entered through the corneal incision into the anterior chamber and across to the meshwork. The tip of the Cahook device pierces the trabecular meshwork, and the blade is used to make an initial central excision at the end. The blade is then repositioned to pierce the TM at a different location towards the direction of the initial incision. This will make a connection that allows for removal of the TM in a clean sweep. This is then repeated on the other side for approximately 120 degrees. The Cahook Dual Blade is a single unit device that is disposable. This is Dr. Constance Okeke, hoping that you enjoyed the video, and if you did, please click on the like button below. And look out for more videos on my eye glaucoma channel on YouTube. And also,
So something that is very nice and useful with the Cahook Dual Blade and is that I have used it on different missions, and although it is certainly single use, you can try and maybe get another use out of it. So if it's sterilized in the proper way, then it can be utilized again. And it is easier, just like the trabectome. So here you fill the AC, the anterior chamber, with viscoelastic. You have a very stable anterior chamber, and you can definitely get pressures in the mid to lower teens with this device, with of course the right patient. And as for angle surgery, the gonioscopy assisted transluminal trabeculotomy is by far my favorite angle procedure or trabecular bypass. And the reason is that it basically doesn't cost the surgical center any extra money, doesn't cost the patient any extra money. And even in my province of New Brunswick in Canada, MIGs are not covered. So if a patient wants to have a Cahook Dual Blade, they actually have to pay for it. If they want to have an eye stent, they actually have to pay for it. The GAT, which you'll see pretty shortly, is all you need is an electrocauter, you need a 5-O-proline suture, and a gonioprism, which all of them, well, not all of them are usable, but these are cheap things to have in your OR. So the first video is actually a simulated video using the Simulide. I'll mute that so everyone can see it's okay. So basically, I'm actually the lead instructor for the ASCRS MIGS course on an annual basis. And basically at the MIGS course, it's a 2-step course. You have a didactic with similar lectures to this, and we have a wet lab. Despite COVID, for now, ASCRS will be taking place in Las Vegas in the summer in July. And we use a similar, the Simul Eye, which is a simulated eye which allows angle procedures to be done. So this, you'll see, you just have to take the cap off, which allows you to see the angle procedure. And we'll see, basically, you fill the eye with viscoelastic. We use a 5-O-proline suture, which you trim, you don't need the needle. And you use a low temp cautery to make a small bulb at the end of the 5-O-proline suture. And this bulb, or the suture, we basically thread through a goniotomy in the trabecular meshwork. So we'll see how this goes, and then we'll see a few videos. And again, what you need is a cauter, and it has to be one of those high or low temp cauters. A phaco machine cauter will not be useful because it does not heat up, and you need the heat in order to make this flange at the end of the 5-O-proline suture. And then you basically need 1 or 2 site port incisions, and you need a main incision in order, which can be up to or 1 or as small as 1 millimeter, because you're going to need micrograspers to kind of advance the suture. So what we're going to see is, so the suture is entered into the anterior chamber, you need coupling material, and what has been made already. So assuming that we're imagining that this is the area of the trabecular meshwork, you can see my pointer, right? It has been, a goniotomy has been done. So the trabecular meshwork was removed. You can either remove it with an MVR blade, or you can use a 25 gauge needle to just excise the trabecular meshwork and have access into Schlemm's canal. And through that goniotomy, you thread the suture either 180 degrees or 360 degrees. And basically what we see here is that the suture is threaded through the trabecular meshwork. And here you kind of see it through Schlemm's canal, and it doesn't always slide in as easily as this. And go more than 180 degrees, you start kind of having a little resistance. And what we see is that the suture was threaded on the right, and now it completed a 360 degree turn, and it came out from the other side. So this will be a 360 gap. And what will be done is you're gonna hold on to the distal end, and sorry, I'll show that again. So you're holding on, you hold on to the distal end, and you kind of pull the proximal one, and it will cause a goniotomy or trabeculotomy. So it will kind of tear trabecular meshwork and create a goniotomy. So we'll see what it looks like in real life. And again, this is by far my favorite angle procedure. So we'll see how it looks. So basically, again, you have a site port incision, you have your main incision. It can be coupled with a phaco, or it can be as a standalone. And what is done here is using the LX ABIC, ab interno canaloplasty. So a goniotomy was done, and now the ABIC device is threaded through the trabecular meshwork, and then basically pulled out. The device is pulled out, tearing the trabecular meshwork. Again, this is a device that requires the special beacon and the special device. I don't have that in my OR, and what I do is I do the usual GAT procedure.
This video describes implantation of the in-focus microshunt, and we'll start by making a conjunctival peritomy here at the superior limbus here. This should be approximately 5 to 6 millimeters in length to allow for adequate exposure of the conjunctiva, as we'll see later on in the video here, to allow for adequate placement of the device. Tenon's insertion is cut and disinserted, as we see. The insertion is about 2 millimeters back.
Sorry. So we don't need the voice for this. So that's the traditional GAT, and this is from Dr. Chang, who's a pediatric glaucoma surgeon in Bascom Palmer. So this is a juvenile open angle glaucoma. So we see the cotter basically causing that small flange within the suture. Something that is very important is if we use too much of a heat, it will just dissolve the entire fibroproline suture. So you have to kind of be very gentle on the heating portion. There's no harm will be done. You just might wind up with a big bulb that won't go through your goniotomy or trabeculotomy. So I actually don't have a low temp cotter in my OR. I have only a high temp. So I kind of press release until it kind of warms up a little bit until I can perform until a little flange kind of results at the end of the fibroproline suture. I usually take 1 or 2 inches, and you'll see that you kind of, there we go. You want to make a small bulb, and it goes through a 0.9 or 1 millimeter sight port. I always try and aim for the nasal and inferior angle. It doesn't matter if I'm doing the right or left eye. We know that we have more collector channels in the inferior nasal angle. So potentially if we open trabecular meshwork over those collector channels, you might get a bit more of an accurate projection. Then Dr. Chan goes on to do a clear corneal incision. It can be 1 millimeter, and injects viscoelastic. I always try and under-inject viscoelastic. Under-inject, you might get some heat reflux from trabecular meshwork, which will kind of be your last trip to know where you're going to. So you can use either disposable or maybe another forceps. And here he actually uses a 23 gauge MVR blade to open the Schlemm's canal and expose open trabecular meshwork and expose Schlemm's canal, and then he kind of just injects some more OVD just to make sure that the trabecular meshwork is, both lips are open, and then utilizing micrograspers, you just thread the suture through, and if we do see some heme, which I love seeing. So anytime we see some blood reflux, that's an actual good sign. It means that the aqueous channels are patent, and you get some aqueous veins or reflux from those collector channels. And I always tell my patients, if we see blood at the end of surgery, this is actually a good sign. So this is one surgery you want to see blood in. And I tell this to the patients because I sometimes see it naturally at the slit lamp, and it's a good prognostic sign. So the suture here was threaded 360. So now the surgeon will so he's still threading the suture either 180 or 180 degrees or 360. And again, the first 180 degrees, the first half of the angle is kind of smoother, typically at the reach and you go for more, you get some more resistance. After the 30 pushes, we can see that the distal end comes out, at which point the surgeon will pull on the distal end. Oops. Yes, you can hear it.
So could you please turn down the music a bit? It's over. We can't hear it over your voice. Yes.
Oh my God. Okay. Sorry. Is it better now?
Yeah.
Okay, sorry, it's the voice. No problem. So basically what the surgeon does now is just removes the suture, and you see how it kind of goes through. And that was a 360-degree goniotomy. And what we see is some heme reflux, which we want to see. So we want to see heme reflux. In my op notes, I actually write +1, 2, 3, or 4 heme at the end of surgery, which will probably help me to know if it was successful or not. So moving on. Any questions about GAT? I think, I think it's within reach for every OR to perform this, and I'm happy that a patient doesn't have to pay for a procedure. I always say that glaucoma is not oculoplastic, so we're not doing a blepharoplasty for these patients, but we're helping, hopefully helping them to preserve their vision. So that's why I love GAT, because basically not much cost to it. So that was the trabecular meshwork. Now we can go to Schlemm's canal devices. So Schlemm's canal or trabecular bypass. And what I'll talk about is the iStent and the Hydrus. Anyone has some experience with either of them? Lily, have you done iStent? Do you have iStents and Hydrus there?
Okay, I haven't used them here. Has anyone? You could type on the chat box. I think we're all in the same page. I don't think we have it here. Yeah.
You don't have the access. Okay. So iStents, and we'll see both. There have been several generations of iStents, and Hydrus is a recent new development. It's a trabecular meshwork scaffold, and we'll see how it goes. So we'll see iStent first. Let's make sure that it's not playing too loud. Is that okay, or is it? Can you hear nothing?
Under implant that happened. First and foremost, with the cataract surgeon, it is very important to identify the structures, and gonioscopy 101, identify the scleral spur, then the trabecular meshwork. With that, you'll be very successful in finding your way. So here we see the first implantation. Here we hear the click and then the charge. And if we look at it, although there's bleeding, which means that it is within the trabecular meshwork, it wasn't really implanted where we wanted it to be. So what we do right now is just proceed as usual. We will implant the second stent. Here I'm looking for the other collector. And here we'll aim the trocar to the trabecular meshwork. And I have to apologize because that bubble right now will move right in front of the implantation. But here we indent, we'll see the V. So I apply a little bit more pressure, not over pressure, and then we'll see a nice implantation right here on the right. And here we confirm that the left stent was under implanted. So what we do is we'll use the previous charge. We have 2 more charges within the injector. I'll expose the trocar, and what we do now is we thread, or we pass the trocar inside of the stent very slowly, carefully, and now I push in, I indent with a little bit more strength, but not too much strength. And once again, we have the bubbles. Today was bubble day, but once we clear the bubbles, we see that the stent is nice and firmly nested within the Schlemm's canal, and the neck is surrounded by the trabecular meshwork. So it ended up being a perfect implantation of these 2 stents, and therefore I consider that now a successful surgery. So here we see a very nice image of both stents, and now we'll proceed to demonstrating the collector vessels. And here we see the BSS going through the episcleral vessels, and here in slow motion. So this was a great case. Thank you very much for watching.
So that was one. And this is the second generation, or iStent G2. There has been the G1, which was an L-shaped device, and this is the kind of second generation, which has 2 iStents mounted in it. In the States, it is indicated only to be done in combination with cataracts, but elsewhere can be done as a standalone. And now we'll see the Hydrus, which is a trabecular meshwork scaffolding device.
The Hydrus microstent is implanted into the eye using an ab-internal clear corneal approach. The incision is made to the right to allow for the curvature of the cannula, which you can see is uniquely curved to follow the curvature of the angle.
What we can see is, so Ike, of course, is very apt with angle surgery. We can actually see him in Schlemm's canal. So if we don't overinflate the eye with viscoelastic, then you will get some heme reflux into Schlemm's canal, and it helps you to see where you want to end up, where your Schlemm's canal or trabecular meshwork implant would wind up. And especially for the hydrus, this is important. It's important, of course, for GAT and the eye stents as well. So we'll just proceed and see how this goes. And this is a beautiful gonioscopic view of the angle.
As you see in its position, the distal tip of the cannula is used to incise the inner wall initially. Only about 100 microns of that distal tip will actually enter the canal. You'll see that there is some torquing of the eye, which is expected, some positive pressure onto the canal to allow penetration. But once this occurs, we will relax our hand slightly and advance the roller wheel to place the device into the canal. Notice how the device is slightly placed in an upward fashion to ensure we have adequate passage. And at this point now, we relax our hand, releasing the tension against the outer wall and allowing the implant to be smoothly directed into the canal. The side interlock releases the inlet from the implantation device, and the cannula is then withdrawn. And we'll now take a look and see the device in its position here, as you see the inlet to the right and the 3 windows to the left. There's normal blood reflux in this case. In fact, it actually helped us to visualize the canal position prior to implantation. And we will now evaluate the position of the device using a Sinskey hook just to manipulate the eye. Notice as the eye is torqued down, you can see 3 windows nicely positioned within the canal, which is where we expect it to be. You'll see the blood reflex behind those 3 windows present in the canal, scaffolding the inner wall nicely and keeping the canal open. The inlet is into the anterior chamber very slightly, and you see the transition zone is where the incision has been made into the inner wall.
Okie doke. So we will move on. So the second, or the fourth stage would be the aqueous production. So we're always dealing with how to improve outflow, but we're never kind of treating the main problem, which is the production. So what we can see, dealing with aqueous production, we can use transscleral cyclophotocoagulation, which is the transscleral continuous wave CPC. Something else that I mentioned is the micropulse transscleral cyclophotocoagulation, which is basically MP CPC. We can do endoscopic cyclophotocoagulation, and we'll also see the high intensity focused ultrasound device. So what I'll show you now is how I do micropulse CPC. So I actually, right after this, I have a clinic where I do micropulse CPC, and I actually have an anesthetist that comes in and blocks the patient because despite it being micropulse and not continuous wave, this is a painful laser. And of course, we target the ciliary processes and ciliary body. So I do it in my office. The anesthetist comes, gives the patients a peri or typically a retrobulbar block. And then we use a micropulse cyclophotocoagulation, and we swipe superior and inferior sclera. I usually use 90 seconds on the superior and inferior, and if I need more dwells, so you see it's kind of a swiping or dwelling technique, I use more than 90 seconds up and down. So I usually write for my notes when I first encounter the patient, I write, I will be doing 90 degrees times 2 times 3, or 90 seconds times 2 times 3, or times 4. And this is, we typically get a good IOP reduction anywhere between 30 and 50%. And of course, these are patients that had failed previous drops, SLT, MLT, or laser trabeculoplasty. And before we proceed with any more invasive procedure, I'd like to use a non-incisional MIGS and this is what I do. A slight disadvantage to the micropulse CPC is that the probe has a lifespan. So once you start treating with the micropulse probe, you have 90 minutes to utilize one probe. So what we typically do is clump a few patients together and do that. Otherwise, it's a big financial burden for the center to do that. I use tear gel in between the dwells, and you need a good coupling material because if you don't have that liquid surface, there's loss of energy in the transmission. So the next technology is the high intensity ultrasound that we'll see here as well. Again, most of, or probably 50% of what I've shown is still investigational. So this is still under investigation. But again, offers a more minimally invasive technique.
Ultrasound circular cyclocoagulation is a new treatment procedure for glaucoma. This fast, simple ambulatory procedure is conducted under local anesthesia and can be performed outside the operating theatre. The IOP-1 system produces the ultrasound energy necessary for the procedure. It comprises a control module and a treatment probe which features.
I'll just stop this and say that this technique, as well as the micropulse CPC, can be done either in a kind of nicely sterile environment, but it can also be done like you saw my video, in a non-sterile way. We're basically not opening the eye, we're not opening conjunctiva, so it doesn't really have to be done in a sterile way. It's just like you do laser trabeculoplasty or iridotomy. It does not have to be fully sterile. Some places err on the side of caution, and it's of course very understandable.
A positioning cone fitted with a suction ring designed to prevent the probe from moving during the procedure. To compensate for variations in anatomy, the probe comes in several sizes. The positioning cone is fixated on the surface of the eye and is used to center the device. The suction ring grips the conjunctiva without misshaping the eye. The transducers that generate the focused ultrasound beams are thus positioned vertically and at the correct distance from the target area, the ciliary body, into which tiny lesions are deposited via focused ultrasound. Setting up the system is simple. The electric cable and vacuum line are plugged into the machine. The procedure starts by placing the cone on the eye and obtaining good centration. Assessment of the quality of centration is based on the uniformity of the peripheral ring of visible white sclera. Proper centration is a crucial step. A minor shift of the device may lead to the focal points being directed outside of the intended target zone and to suboptimal results. Once the cone is in position and centered, suction is activated and the treatment probe inserted. The probe is filled with liquid to allow the ultrasound to propagate. The control module is used to program the firing sequence and to define the number of lesions to be made in the ciliary body. The procedure begins. The module automatically executes the planned shot to produce the required number of lesions. The piezoelectric transducers are made of ultra-thin ceramic, about 250 microns thick, coated with metallic electrodes with a curved surface. The transducers are set to vibrate at a very high frequency, 21 MHz, and produce a beam of ultrasound of a known shape which converges onto a focal line. The beam travels through the liquid and enters the eye. At the focal point and focal point alone, irrespective of the presence or not of pigment, the temperature reaches 80 degrees Celsius almost instantly and gently coagulates the tissue without an explosive effect. An experiment is carried out to observe the thermal effect of focalized ultrasound. A treatment probe is used to fire into a transparent heat-sensitive gel. As we can see in these pictures, the lesion gradually forms as a result of the spreading of heat around the focal line. The 6 lesions are deposited into the theoretical ciliary ring. One of the most exciting characteristics of high-intensity focused ultrasound is the precision of the lesions and selectivity of the thermal effect. In optic microscopy images, we can clearly see the coagulated tissue and the sharp boundary from the adjoining tissue, which is fully preserved. Thus, the heat involved in an ultrasound treatment does not affect the sclera, conjunctiva, iris, or crystalline lens. This precision and selectivity translates into low risk and excellent tolerance. In scanning electron microscopy 7 days after the procedure, it is interesting to note that the basal layer of the ciliary processes is intact, while the epithelial cells have disappeared, leaving the basal layer bare. The efficacy of this new method to treat glaucoma can probably be explained by a dual effect in the coagulation of the ciliary body. One acts on the reduction of inflow of aqueous humor by atrophy of the ciliary processes, while the other acts to increase outflow by widening the uveoscleral pathway. This has been observed in the majority of patients in UBM pictures and in animals as seen in this optical microscopy image. Clinical studies conducted since 2010 on several hundred patients in 6 countries have demonstrated this technique to be effective in around 70% of the population treated, with patients suffering from advanced refractory glaucoma. No severe hypotony or IOP spikes have been observed to date, and in the majority of cases, the effect seems to be stable in time beyond a year. Lastly, the overall tolerance of the UC cubed.
So we see that this at the moment is showing some promise. Sorry, let's see. Okay, so a territory that is showing some great interest is the supraciliary or suprachoroidal space. And we know that we had the CyPass device that was withdrawn from the market for endothelial cell loss. And here we have 2 devices that potentially can go in the supraciliary or suprachoroidal space to drain aqueous. Again, this is a experimental device that, as of now, we'll just see an illustration because there are no videos as of yet in human.
MiniJect is revolutionary microinvasive technology which reduces IOP by optimizing the drainage path from the anterior chamber to the supraciliary space. MiniJect's innovative star material is made of soft and flexible medical-grade silicon, which conforms to the eye anatomy. Its structure consists of a microporous multi-channel matrix. The green-colored ring acts as a visual clue to control the implantation depth of the device. The MiniJect implant comes preloaded in a transparent sheath connected to a handle. Sliding the wheel on the handle allows for precise device implantation. MiniJect has been designed for safe and easy implantation. Fast and accurate insertion can be achieved in a single-step procedure. The shaft is gently inserted through the anterior chamber towards the iridocorneal angle. Using a regular gonio prism to view the angle, the sheath is advanced between the scleral spur and the ciliary body. The MiniJect sheath is flexible with an atraumatic tip, so it conforms readily to the scleral curvature. Correct placement is achieved when the green ring is at the level of the scleral spur. Sliding the wheel retracts the protective sheath and releases the implant. MiniJect enhances the physiological aqueous pathway from the anterior chamber to the supraciliary space, reducing IOP. Over time,
Okie doke. So this is the iStar Mini Jet. And another subconjunctival, this is a subconjunctival implant, which is showing promise. It kind of reminds us very much of the iStent, of the Zen gel implant, which does allow subconjunctival flow. It's less of a minimally invasive device because it does require conjunctival piridomy and is not done ab internal, but is performed ab external. So we'll see this one as well. And this
video describes implantation of the
device that can actually be in patients that perhaps have more tendency for conjunctival or tenon scarring. So we'll see this video again. It kind of reminds very much of the Zen gel stent. And I think I had a talk with you guys about this a couple of months ago.
The in-focus microshunt. We'll start by making a conjunctival piridomy here at the superior limbus here. This should be approximately 5 to 6 millimeters in length to allow for adequate exposure of the conjunctiva, as we'll see later on in the video here, to allow for adequate placement of the device. Tenon's insertion is cut and disinserted. As we see, the insertion is about 2 millimeters back from the limbus, and it's important to cut tenons here, undermined, overlying the episclera, and be sure to release tenons and raise the tenons and conjunctival flap posteriorly. The Westcott scissors are again used to cut that insertion point, and then blunt dissection is used posteriorly in 3 different directions here, left, right, and posteriorly here. The device is in total length 8.5 millimeters, and so we do need to make sure we have a good posterior dissection, making sure we've released any attachments from tenons onto the episclera. And the blunt Westcotts again are used to undermine and ensure we have a nice raised flap. You can see again we're mobilizing the flap, making sure we have a good raised flap here. A bit of lidocaine injection here will help for analgesia. Dental cautery is used at the limbus and the episclera and sclera in preparation of the scleral dissection here using a 23 gauge tapered pencil cautery. We now will use 3 Lasix sponges that have been soaked in mitomycin C, 0.2 milligrams per cc. These are large Marisol sponges here, placed here under the conjunctiva and tenon's flap here. And these 3 sponges will allow for a broad application of mitomycin C, as we can see here, into the area where the intended bleb will form. We then take a 3 millimeter marker here, and we'll mark from the limbus here. As you'll see, we have the surgical limbus visualized here, anterior and posterior limbus. The mark is at the anterior limbus here, and we see now the 3 millimeter point here, which will start the dissection here. We will then use a 1 millimeter micro knife here. Note the bevel of this knife here creates a 2 millimeter tunnel from the tip of this knife to where the bevel ends, and therefore this tunnel will be essentially 1 millimeter wide by 2 millimeters long. Where we want to end up here is basically at the level of the scleral spur, which is where the entry point will be in the anterior chamber shortly, and therefore going 3 millimeters back from the limbus approximates where this point will be. Alternatively, one can basically mark from the scleral spur 2 millimeters back and dissect anteriorly to be sure of adequate length. Next, 25 gauge needle here is used, bent at the hub here, basically retracing the path of that 1 millimeter blade, reaching the spur as we see here. Once we reach the spur, we dimple down to create an iris plane entry into the anterior chamber. This is critical to turn the blade down here, so we're entering at the iris plane here to avoid anterior placement of the implant in close proximity to the cornea. And by doing this, we now create an implant that will be placed just at the iris plane. So that change of direction is very important. Here is the IMS implant here. We see the fin here that's being held by the forceps. The implant itself is 8.5 millimeters long, 4.5 proximal, and 3.5 distal to the fin. By choking up on the implant, we place the implant bevel up here through the tunnel here, slowly advancing this forward, and we'll see the tip enter the anterior chamber. The fin basically then is occupied nicely in a relatively self-sealing manner into that scleral tunnel that was created with that 1 millimeter knife. And there we see the entry point here at the spur, entry into the anterior chamber, and again ideally at the level of the iris plane. Using a thin wall 23 gauge cannula, blunt cannula, we'll inject BSS into the eye here, essentially to check for patency. By doing this, we see a little bit of air bubble here emerge from the proximal end of the implant. And once we inject BSS into the eye, we'll lift the implant up. We notice here the 70 micron lumen here, and we see the BSS here emanating from that lumen. The width of the device, by the way, external diameter 350 microns, and the lumen diameter is 70 microns. The implant then is placed very carefully under the conjunctiva and under tenons as well. Very important here, we lift up the tenons here so the implant lies just on the sclera, the bare sclera here, avoiding the implant from being embedded into the tenons layer. We will then be sure that we have good placement here without any twisting of the implant here, and then we will pull both conjunctiva and tenons anteriorly. Again, critical point here to avoid tenons from gathering at the distal end of the tip. We want to ensure we have adequate position of the tip under tenons layer. To facilitate this, we're actually going to close tenons and conjunctiva in two separate closures here. Here we're using 9.0 Vicryl on a specialized blunt spatula needle here, allowing us to place tenons here anteriorly at the insertion here. Again, ensuring and avoiding it from retracting here, potentially then occluding and gathering at the distal end of the implant. We will then close the conjunctiva here, typically using here 9.0 Vicryl again. Here placed here in two wing positions here, making sure that we have a nice taut closure. The cautery which has been applied at the limbus will help for watertight closure, and you'll see here we'll also use a horizontal mattress here placed at the limbus. One of the advantages of this implant here is a nice posterior drainage point into the area where the mitomycin has been applied, and therefore we avoid the anterior blebs and anterior potential flow, and therefore wound leaks are quite rare with this implant. The posterior nature of the bled, of course, is ideal and away from the more active replicating cell of the limbus. Here we're using a surgical gonial lens to evaluate the position of the device, again, ideally at the level of the spur, just anterior to the iris. And here we see a nice position of the implant here parallel to the iris. Adjusting the BSS here shows a nicely formed, well-pressurized eye here. 70 micron lumen, 8.5 millimeter length of the implant, avoids hypotony. And we have a nice sized bleb here with pressures that typically will end up being in the high single digits in the early postoperative period.
Okay. Okay.
This is a surgical technique for trabeculectomy, starting with a pair of blunt Westcotts and a pair of ring fecnoforceps. The conjunctiva is incised here.
So I have one last technology to discuss, which is it's called MIMS. So it's a minimally invasive microsclerostomy, and it is a by chance it is an Israeli development, and with that we will be ending my talk. So again, this is produced by the Sinoculus company. It's basically a microtreffine, which creates treffines the sclera, either ab interno or ab externo. It is performed, let's see. So again, it's an to answer to the minimally invasive tenets, it is done through a clear corneal incision. You can use mitomycin injection subconjunctivally. The introducer is introduced through the drainage system into the drainage angle, and basically the treffine makes a small fistula through the sclera to allow subconj filtration. In a way, it's kind of a minimally invasive trabeculectomy, and the remainder of the sclera is removed, and we'll see how it is done in this video. So you can either use viscoelastic or mitomycin to separate the conjunctiva from tenon, just where the future bleb will take place. And we see that this is a pseudophakic eye. And then through a clear corneal incision, which can be as small as 1.2 millimeters, you have to inflate the eye with viscoelastic. Of course, you can either use Myostat or Myocol to constrict the pupil so you don't have any iris tissue in the drainage angle, followed by viscoelastic. A cohesive is usually enough to give you a good consistency of the anterior chamber. And then the microtrefine is used. It can be tested initially before entering the eye. And you can use a gonio prism just to see exactly where you are in the drainage angle, but it is not a must. You can see that here, the surgeon kind of knows exactly where the drainage angle should be. And you'll see, there we go, you can see the microtrefine comes out subconjunctivally. And that is the procedure. So that's another novel technology that is available, still under investigation. And that is all for me for today. I'll be happy to take any questions.
Okay. So thank you very much, Dr. Shoham Hazan, for taking the time bang in the middle of your busy day to give us this talk. And I can attest on everyone's behalf that it's been enlightening to have an opportunity firsthand of your experience on the new horizons in glaucoma surgery. There are a couple of questions. I think I saw 2 on the discussion box. You can bring, I think now is the time, if you'd like to, you could type in your questions. So, I think it was Dr. Jaffaji asked if the trabeculotomy concept is similar to the one on the Otili machine has. And also asked how much the Cahook blade costs. And if it's in Kenya.
Yeah, I'll answer the second question first. So the Cahook dual blade is typically around 500 or 600 Canadian dollars, which is I want to say it's probably 400 US, 450, which is probably one of the cheapest MIGS devices that you will have, which is great. I mean, we don't, when I just think of the other bypass procedures that are maybe 11 or 1,300 US dollars, it's not within reach for everyone. So in Canada, for example, our health system is a public health system. Patients don't expect to pay. And I don't expect a glaucoma patient to pay for their glaucoma surgery. So in that respect, the Cahook dual blade is, I think, somewhat within reach in comparison to the other devices. And of course, the GAT, which is basically costs almost nothing. So that's what I advocate for it, just because I like it a lot. The results are pretty consistent, and again, patients doesn't have to pay, and even our healthcare system. So we know public healthcare is always short of money. So I kind of think about that as well. The question regarding trabectome and the ortly, I'm not really sure what the second one is.
Could you please type in the chat box? I think it's a phaco vitrectomy machine, but I'm not sure which feature it has. Let's see. I'm not seeing.
Oh, I see it now. I'm not really sure. I'm not really sure what the ortly machine does. So it's not, so the trabectome is not a vitrector, right? It is an electrocautery. It has like a footstep, or there we go, that kind of goes into Schlemm's canal. So it's not a vitrector that eats the trabecular meshwork, but it's an electrocauter that basically cauterizes trabecular meshwork and helps remove it in that way. So it's not a vitrectomy machine per se.
Yeah, we're getting a couple more questions.
Sure.
I think Dr. Jaffaji asks again, which of these, okay, we've gone through a number of devices. So which of these devices has the least complications, best outcomes of IOP control? He thinks it's an unfair question, but I was actually going to ask you, like, what's your favorite mix?
So my favorite MIGs would be, again, I'd have to say GAT again. I'm kind of sounding like a broken record, but I find that GAT helps me reach IOPs that are consistently in the mid to even lower teens, something that we talk about, and the MIGS skeptics always say that minimally invasive glaucoma surgery is minimally effective. So I don't think so. So I find minimally invasive glaucoma surgery, if you're doing it in the right patient and you perform the right procedure, you'll get the results that you're anticipating. When doing MIGS in either mild, moderate, or advanced cases, where you want to have either mid to lower teens, I do find that the GAT is, I find, more consistent. I find that I have less complications with it. You do get heme reflux, and I have about less than 1% chance, 1% rate of an 8-ball hyphema. So I had a few patients that by week 1, the entire eye filled with heme. I think you find it less, for example, in Cahook dual blade. I do a fair amount of KDBs, and I find that there's less heme with them. Is the Cahook dual blade is the reason because you actually excise and remove the entire trabecular meshwork? Is that the reason? I'm not sure, because the heme typically comes from the collector channels and aqueous veins distal to that. Is it because KDB you don't KDB, you do maybe 90, 120, or if you're lucky, 180 degrees. GAT, you sometimes do 360 degrees, so you get more collectors, more chance of heme. So it's hard to say what's the best fit. I think the best fit would be what works best in your hands. And I must admit that I've kind of tried everything, and I keep on trying new things, and I try and perfect the old things. For example, the subconj, one of my favorite subconj MIGs is Zen, because I've had probably more than, I want to say, 300 procedures with it. And I've tried the traditional ab interno Zen, and I've done ab externo open or transconj. Now my favorite Zen procedure is to do an air OVD technique. So I separate the conjunctiva with air and then inject viscoelastic, and then through the conj and OVD and the air, I inject the Zen into the AC. With Zen, you tend to have a little lower target pressures than you do with a traditional, let's say, GAT, KDB, iStent. So the trabecular meshwork bypasses, you typically get to mid-teens, sometimes kind of lower. With Zen, it's almost consistently around 12 or lower than that. But with Zen, you are managing a bleb. So some of us, when we do MIGS, we don't want a bleb, because it kind of reminds us of trabeculectomy in tubes.
Yeah. So I think he also went on to ask if it has the HDF system, and is it an electrocautery? I think you've answered that in your question.
Yes, so is that for the trabectome? So the trabectome, oh, for the Cahook?
Wait. That's for what? Could you please type, Dr. what it was for? It's for the trabecule.
For the trabectome. So the trabectome, we have the traditional trabectome, which you might actually, Lily, have used in Toronto, which had the electrocautery console to it. The current trabectome, which was bought by MST from Neomedics, it's no longer has this electrocautery console. They have the Trab X and Trab X Plus, which reminds us very much of the Cahook dual blade. The Trab X is similar. It has the same kind of similar idea as the KDB. So it kind of peels off trabecular meshwork and opens Schlemm's canal. And the Trab X Plus is connected to the IA of your phaco. So it doesn't anymore have that electrocautery console to it.
I'm happy you talked about patient selection with, and I think we're getting a number of early glaucomas, and I think that's where maybe MIGS would play a bigger role. And I rotated for my mix with Dr. Basa Khan, and I think the way he put it was the real estate idea. A lot of our glaucoma surgeries interfere a lot with the conjunctiva. And I'm happy you came up with that stepwise approach, and we're trying to avoid the conjunctiva as much as possible, because these surgeries fail, as we know, life expectancy is increasing. So I think that's where MIGS has been evolving a lot. And that's what I saw maybe for us in our setup would be an opportunity for looking a bit into this, not just staying there back, oh, we don't have these things. And I see an opportunity for that. Yeah, what do you think? Like, especially, and especially for me, I'm seeing the subchoroidal space, I like the mini inject. That seems, at least you're avoiding conjunctiva. There seems to be little reports on choroidal detachment. So what do you think?
Right. So I've had some experience with the gold shunt and the CyPass as well. So the gold shunt is, again, a device that was kind of initiated or originating in Israel. And the CyPass also, we've seen it in recent years. My concern with those suprachoroidal implants is that we don't really understand the suprachoroidal space that much. And there is a concern of scar tissue and excess scarring in the suprachoroidal space, maybe because we've got more blood vessels there, maybe we have more fibroblasts that are coming as well. So I think the suprachoroidal space is an interesting space, definitely, because we're avoiding conjunctiva. I don't know if we're still, if we're there already. So that's, and you are causing a little cyclodialysis cleft with any device that you put in there. So the question is the cleft working until it closes and then pressure spikes? So that's why for now, I'm not sure we're there yet. Should we do suprachoroidal implants with some steroid coating on them to prevent scar tissue? We know we can, the eye or endothelium won't tolerate mitomycin inside the eye, so we can't coat the implant with mitomycin. 5-FU, some people say that it's not as toxic in the AC. I'll be very worried to put 5-FU in the eye. So it's, it's a space that needs more work and study into. But definitely MIGS allows us to intervene sooner. And angle procedures such as, again, such as GAT, KDB, are very good options and are not that difficult to study or learn. The learning curve is not as steep as a trabeculectomy or a tube shunt. So, and if that fails, you can always take the plunge and do a conjunctival traditional procedure.
And many of our patients here have actually the primary open angle kind of glaucoma. So I think a lot of this MIGS procedure is actually in the angle. So we do have a lot of opportunities for MIGS, in my opinion.
And I think that's absolutely right. So you are dealing with a lot of POAGs, and just like I was late coming in because I had a young, very advanced open angle glaucoma patient in his 30s, and I'm 45. So I'm looking at him. He's in his 30s. He and I will probably live a long time together. So I'll probably have to do multiple procedures before I retire and before he passes on. So I was kind of thinking, I was like, okay, what? Yes. So it's going to be a long marriage between us. So definitely a laser trabeculoplasty can be a good option as a first intervention. And then for sure an angle procedure. So a GAT, KDB, trabex, trabectome, trying and relieving the resistance in the juxtacanalicular trabecular meshwork. At a later point, maybe even doing a Zen, but probably this guy will wind up with 1 or 2 tubes in his eyes by the time he's 50 or 60, I want to say. or maybe sooner.
So I think we have a couple last questions, I think, but thank you so much. It's been really a stimulating session. So, okay, Dr. Jaffa was talking about the high frequency deep sclerostomy. I think that's what he was referring to. Our biggest disadvantage is the companies are restrictive. They don't want to supply us with the devices in spite of telling them we have done training and wet lab. And then thanks for your wonderful talk. They found it very informative and stimulating.
So I'll tell you, some of the companies would want to promote their devices and want to promote their education. I know for a fact that, for example, New World Medical, that produces the Ahmed glaucoma valve, the new ClearPath, and the KDB, they're very into education, for example, and they are, for example, someone that you might want to connect with. Other companies as well, they see an opportunity in a market that maybe hasn't been infiltrated by minimally invasive glaucoma surgery. And Lily, we can discuss that kind of offline, and I can maybe give you some contact people that will be happy to train and maybe come, who knows when this COVID thing will be done, but come to Kenya and help train, or maybe bring you guys into a different place once COVID's over and help train. And the nice thing, again, about minimally invasive glaucoma surgery, that it does not have to be done by a glaucoma specialist. So if you have a skilled cataract surgeon that is willing to master a MIGS procedure, that would be huge for you guys, where glaucoma surgeons are so scarce. So if you can master a decent, safe procedure, you can always combine it or do it as a standalone procedure. So that's also pretty good about MIGS.
Yeah, so I think, thank you so much, everyone, for holding up to this time. It was a very stimulating session, Dr. Nia. And I appreciate the audience. Without you, this evening would not have happened. So that brings us to the end of tonight's CME. At this time, I'd like to have my colleagues, I think the sponsors, speak so we can finish up by saying thank you for attention, at least from our part. Thank you so much, Nia.
Thank you.
Yeah, thanks so much.
Thank you.
I did it.
Brenda from Novartis today is going to give us a 5-minute talk, as they have been the sponsors for us for this session today evening. I know we have run out of time, but bear with us for the next at least 5 minutes. Thank you.
Okay, thank you. Good evening, everyone. My name is Brenda Sigu from Novartis. I'm a medical representative, and I will briefly take you through one of the most unique eye drops that we have introduced in the market, and this is Simbrinza. So times you may have patients who are on monotherapy regimens or on different regimens, but they're not getting the desired IOP reductions that you're looking at. What I'm going to share with you today briefly will give you hope for such patients, even as you try and improve their quality of lives. So what is Simbrinza? We bring Simbrinza basically as a choice for add-on power, and we will look at this briefly. So Simbrinza is indicated for the decrease of IOP in patients with open-angle glaucoma or ocular hypertension, especially for patients who are on monotherapy regimens and they're not being well controlled. And Simbrinza is a fixed dose combination. It has brinzolamide and brimonidine. The preservative is benzalkonium chloride at a very small percentage of 0.003%. When you come to its mechanism of action, Simbrinza is a combination of both a carbonic anhydrase inhibitor, that's brinzolamide, and an alpha agonist, which is brimonidine. So brinzolamide acts by decreasing the aqueous humor formation, whereas brimonidine suppresses both the formation of aqueous humor while at the same time increasing the uveoscleral outflow. So does this mean that this is the only advantage that you'll get from Simbrinza? Not at all. The brinzolamide that is one of the active ingredients in Simbrinza has been associated with nocturnal efficacy. So this means that if your patient is on Simbrinza, they'll be able to get the advantage of the additional IOP reduction as well as the nocturnal efficacy associated with brinzolamide. And let's just for a moment look at this treatment possibility that we are talking about, it being an ad for these patients who are not being controlled efficiently, who are on for example, on a PGM monotherapy. There was a study that was done to actually show the comparison of using Simbrinza as compared to the individual components, that is brinzolamide and brimonidine as an add-on therapy to a PGA monotherapy. And for this particular study that was done, the design of the study is as is presenting on the screen. We had patients going through the screening and the washout period, after which they were randomized to 3 arms. So one arm was given brinzolamide, the other arm was given brimonidine, and the other arm was given Simbrinza. So basically, the study was double masked, it was randomized, it was multi-centered, active control, and the study actually ran for quite some time, but the primary efficacy endpoint was done at 3 months. And what was the results of this study? It is very pleasing to actually find out that the results of the study were promising, because for patients who were on Simbrinza, it was found that the IOP reduction was statistically superior compared to the IOP reductions for the individual components, that is brinzolamide and brimonidine. And the significance was actually seen, and I'm very sure for your patients would also appreciate it, because the additional IOP reduction was found to be between 7.7 to 9.5 mm of mercury reduction. What does this mean for your patients? As we've seen here, the dosing of Simbrinza is BD, just morning and evening. So this means that if this is a patient who's on a PGM monotherapy and they're not being well controlled, just adding Simbrinza to them as a BD on a BD dosage, they'll be able to get an additional 7.7 to 9.5 mm of mercury reduction. We'll be able to have this patient going on with their normal life. They'll be able to see their friends. They'll continue doing whatever they do to be able to just fend for themselves and continue with their life normally. So let us help these patients to continue having the brighter future that they're looking at by giving them Simbrinza. And when we do that, we'll be able to help them retain their vision. So in summary, what does Simbrinza do? Simbrinza, as a choice for add-on power for your patients, will be able to offer them up to 7.3 to 9.7 mm of IOP reduction. This is not a one-day reduction or a month reduction. It is a consistent 24-hour IOP lowering coverage. So this is something that will be consistent throughout, provided that they will be compliant to their eye drops. And something else that is important is that when risk necessity was done, it was found that there was no additional risks which were identified with Simbrinza. And this is very important, because sometimes there would be worries, why should we do this? But this is a yes for you, that with Simbrinza, your patients will be safe. And something else is the synergistic mode of action that they'll be able to get from both brinzolamide and brimonidine combination. It being a unique and the first combination that does not have a beta blocker, you can be sure that your patients are well placed in the glaucoma space. And because of this, we then hereby kindly request you to pass the benefit of Simbrinza for the patients who will be able to need it. Thank you.
Thank you, Brenda. We will sure be going to try and give some of our patients the benefit of Simbrinza. So today we have come to the end of our CME. Would like to give thanks very much to Dr. Shoham Hazon for a wonderful presentation. And also thank you, Dr. Lily, for moderating for us. It was a very enlightening session. Our next CME is going to be in 2 weeks' time, and we will give you the topic of presentation as time goes. Also like to remind all of us, please let's send our name and the name of our institution to the host for today's meeting, which is Ophthalmological Society of Kenya, for purposes of CPD points. Thank you all. Have a good night.